Hello everybody. Today we are going to discuss about the DIC, the question which was asked in October 2023 DRNB Critical Care Examination. So the question was risk factor for DIC, diagnosis and management. So first risk factor is sepsis. It should be emphasized that DIC is not a disease in itself, but is always secondary to the underlying condition that causes the activation of coagulation. So about 35% of cases of severe sepsis may be complicated by DIC. So factors involved in the development of the DIC complicating infections are microbial membrane constituent such as lipopolysaccharide, lipoteichoic acid, exotoxins evoking strong immune response and release of cytokine. Now next risk factor is malignancy. Both hematological malignancy and solid tumor may be complicated by DIC due to expression of procoagulant factor by the tumors. So the incidence of DIC in cancer is not precisely known and may be depend on the diagnostic criteria used. However, some series, in particular in patients with metastasized adenocarcinoma or lymphoproliferative disease, report an incidence of up to 20% in consecutive cases. The risk of thrombosis is greater than the bleeding. In severe cases, thromboembolism in conjugation with the bleeding can be seen. Severe trauma in another clinical condition is commonly associated with the DIC. Systemic cytokine pattern in patients with severe trauma have been shown to be virtually identical to those with the septic patient. In addition, release of the tissue material like tissue thromboplastin, in particular with the head trauma into circulation, endothelial disruption, may constitute the systemic activation of coagulation. Then obstetric calamities like placental abruption, amniotic fluid emboli, acute and fulminant DIC may occur. The degree of the placental separation into patient with abruptio placentae correlate with the extent of DIC, suggesting that the leakage of tissue factor from placental system into maternal circulation is responsible for occurrence of DIC. So the clinical condition most frequently associated with DIC are severe sepsis, for example, gram-positive, gram-negative, malaria, and hemorrhagic fever. Impact of precipitating condition is thrombosis may contribute to organ failure. Then malignancy like solid tumors like adenocarcinoma, acute promyelocytic leukemia or monocytic leukemia. Primarily thrombotic consequences or venous thromboembolism. Severe thrombocytopenia and factor deficiency may lead to bleeding. Then trauma like multi-trauma, brain injury and burns. Primary feature is acute bleeding followed by thrombosis. Obstructive complications like abruptio placenta and amniotic fluid embolism. So impact of precipitating condition, it results into the profuse bleeding in combination with the thrombotic complication. Then vascular malformation like Kasbach-Mariette syndrome, giant hemangiomas, other vascular malformation, large aortic aneurysm. It results into bleeding primarily with the severe thrombocytopenia and hypofibrinogenemia. Severe immunologic reaction like transfusion reaction. Heat stroke like thrombotic feature more commonly associated with the bleeding. Post cardiopulmonary resuscitation, thrombosis is the greater risk than the bleeding. Now the pathogenic pathway, initiation and the propagation of the procoagulant pathway with simultaneous impairment of the natural anticoagulant system and suppression of endogenous fibrinolysis as a result of systemic inflammatory activation are lead to the platelet activation and fibrin deposition. Important mediators that regulate this process are cytokines such as interleukin 1, 6 and tumor necrosis factor alpha. In addition, recent studies point to the prominent role of intravascular webs like neutrophil extracellular traps consisting of denatured DNA from damaged cell and entangling neutrophil, platelet, fibrin, and cationic proteins such as histone in the development of thrombus deposition. Thrombin generation in the DIC is initiated through the tissue factor 7A pathway that activates the downstream coagulation factor. Tissue factor may be expressed by activated monocyte, but also by vascular endothelial cell or cancer cell. Besides inflammation causing procoagulant effect, the activation of coagulation also modulate inflammation. In DIC, all physiological anticoagulation pathways are functionally impaired. Firstly, marked imbalance of tissue factor PI function in relation to increased tissue factor dependent activation of coagulation has been described. In addition, significant impairment of protein C system may further compromise adequate regulation of thrombin generation. This is caused by cytokine-mediated down-regulation of thrombomodulin expression on endothelial cells in combination with decreased synthesis of protein C and fall in the concentration of the free fraction of protein S, together resulting in the reduced activation of the protein C. Lastly, the plasma level of antithrombin, the most prominent inhibitor of thrombin and factor Xa, are significantly reduced due to combination of consumption, degradation of elastase from the activated neutrophil, and impaired synthesis. In addition, endogenous fibrinolytic system is largely shut off as a result of sustained rise in plasma level of plasminogen activator inhibitor, which is a principal inhibitor of plasminogen activator and plasmin generation. So this is the schematic representation of pathophysiology of the DIC. Now the diagnosis of DIC. For diagnosis, there is a scoring system. So in which the platelet counts, if more than 1 lakh, 0 score, if less than 1 lakh, 1 score, if less than 50,000, 1 score. Now the level of fibrin marker like D-dimer and fibrin degradation product, if there is no increase, 0 score, if there is increase but less than 5 times of upper limit of normal, 2 score, if there is strong increase, then 3 score. Then prolonged prothrombin time, if less than 3 seconds, 0 score. If more than 3 seconds and less than 6 seconds, 1 score. If more than 6 seconds, 2 score. If fibrinogen level, if more than or equal to 1, 0 score. If less than 1, 1 score. Now about treatment, if there is a clinical suspicion of the DIC, like underlying condition to be associated with DIC, low decreasing platelet count and prolonged global clotting assay, that is PT and APTT, use DIC scoring system. If less than 5, no DIC. If more than 5, then the diagnosis is compatible with the DIC. Then we have to treat the underlying cause. If it is an active bleeding or no active bleeding or no need to undergo invasive procedure, then we have to give the platelet transfusion to keep the platelet count of more than 30,000. Plasma or factor concentrate administration to keep the prothrombin time less than 3. Prolong and keep fibrinogen less than more than 1.5 gram per day. Vitamin K supplementation in case of vitamin K deficiency. Antifibrinolytic treatment in case of excessive hyperfibrinolysis. If there is no major bleeding or thrombolysis, give the prophylactic low molecular weight heparin. If there is overt thromboembolism or organ failure related to the clot formation, then we have to treat it with therapeutic anticoagulation treatment like unfractionated heparin and restoration of the natural anticoagulant pathway under evaluation in clinical studies. Thank you, guys.